आज तेरे मुंह पे तेरी पूरी तरह कौन डोंट அவனுக்கு கிடைக்கிற
Hello everyone. Can you hear me? Can you just text with a message or something? Okay. Uh, Thank you. We'll just wait for a couple minutes. There are some people who are still joining, and we'll start with that. Okay. Just hold on for some time. Can everyone hear me again? Can someone please confirm this?
Yes, sir,
Okay.
you are audible.
Okay. Thank you so much. So, uh, a very good afternoon to everyone present. Thank you so much for giving me your precious Sunday time. And we've already wasted a lot of time. So let us just directly dive right into the presentation. I'm going to share my screen now. Okay. Can everyone see my screen?
Yes, sir.
All right. Okay. So once again, thank you so much everyone for registering for this advanced interior composite restorations. I'm guessing you have already maybe attended my basics webinar, or you have at least done some composite restorations. And even if you haven't, I'm still going to cover a lot of basics as well. So nothing to be worried about. For those of you who don't know me, my name is Dr. Srujan, and I've completed my undergraduation from Rural Dental College, Loni, and I was in Savita Dental College, Chennai, for my fellowship in aesthetic dentistry. And these are the topics which we are going to understand today. We'll start with case selection, then shade selection, cavity, surface treatment, palatal shelf, composite layering, replicating anatomy, finishing and polishing, and we'll also be covering some additional clinical tips. So before we start, I want to share this one thing with you, which I have learned through experience, and a lot of participants who must have attended my previous webinars must be familiar with this slide, which is achieving excellence. And that is possible with only three things, that is, what, why, and how. So you need to understand what is the subject you're trying to learn, why is that subject important, and how can we master that. And this is a stepwise process. And with this, no matter what thing you are trying to learn or trying to understand or trying to excel at, you're going to get it right. So let's start with some basics. Composite is a tooth colored resin based material which is used in restorative dentistry. It is composed of resin matrix and inorganic filler particles, which can be glass or quartz. There are many types, but the basic division is macrofilled, microfilled, or hybrid, which is based on the size of filler particles. So macrofilled is going to have filler particles with greater diameter. That's why it is good in strength but has poor aesthetics, because the larger filler particles cannot be very well polished. Similarly, microfilled is going to be very good at polishing, so it will give high aesthetics and low strength. And there is hybrid and a lot of such combinations, such as nano hybrid, universal, and a lot more. So let us understand why composite restorations is really, really important. It is a minimally invasive procedure. You can complete a good composite restoration in one single visit, which patients absolutely love. It is comparatively less expensive, which patients love even more. Then it is easier to repair when you compare it with any indirect restorative procedure, for example, a crown or a veneer. It is not that easy to repair, but composites are very easy to repair. You are the master of technique, and that is why it is super satisfying. right? That's why composite is like one of the most versatile procedures in dentistry, and it is high time that we should really understand and master this procedure. Now, when we are going to master composites, there is one aspect which we need to understand, that is predictability. We need to achieve predictable results, right? Results which we know are going to last for a good amount of time. For this, there are some points which we need to take care of, which is case selection, material, and technique. Right? If you understand these 3 points and you select cases, you use the right material for that specific case, and you use the best technique you can, there is almost no or very little chance that your composite is not going to be a good case or not going to give a good result. So let's start with case selection, and this is very important because as we have discussed, that composite is very versatile, but there are some limitations to it, right? So case selection is the most important step. Composite is a conservative, cost efficient procedure with high versatility, but can still not be the right solution for some cases. Okay. In order to provide aesthetics and long lasting predictable results, some points should be considered before starting direct composite resin restoration. So these are the 5 points we need to look out for as soon as we are considering a composite case. First is the occlusion, most important. Second is moisture control. Third is hygiene, which is the oral hygiene, patient hygiene. Fourth is patient cooperation, and fifth is unrealistic patient demands. Okay, we are going to understand this in a little more detail. So when we are looking for occlusion, these are the red flags we need to look out for. First is bruxism. If the patient is a bruxist, then you will very clearly see atresion and a lot of such things, which you can see in this picture. And as you can see, even the natural tooth enamel cannot last this strong bite force. Then composite is like, just cannot be compared. So we need to understand that composite cannot be given in patients with bruxism. Another thing is if the patient has a previous fractured restoration in the anterior region, then you need to understand that patient maybe has a strong bite and we need to look out for that. Okay. The second point is moisture control, which includes gingival bleeding, excess salivary flow, glossy appearance instead of frosty. And this point I'm going to explain to you in some time. And the last point as well. So in this picture on the right, do you see the gingival, the marginal gingiva is so inflamed that as soon as I started with cord packing, there was bleeding which started. Right now, imagine you're putting a rubber dam or you're just doing a normal procedure and blood starts rushing out of the marginal gingiva. What do you think is going to happen to your composite which you are about to cure, or the hybrid layer which you probably have already formed, or a lot such questions just arise. So it is just better that you either achieve total isolation or you do not go for composites at all. And this is the frosty appearance I was talking about. Now, when we etch any tooth, we see frosty appearance, right? As we can see in this 2 pictures. So now after rubber dam isolation, this frosty appearance is going to stay. If there is any moisture leakage, the frosty appearance is going to go away and it is just going to turn glossy again. Now in this case, I have given premolar to premolar isolation with active floss ties, which totally prevents the flow of blood or gingival clavicular fluid or saliva, which is good isolation, which is adequate isolation we need for composite cases, right? So this is one thing you need to look out for. There should be frosty appearance and the glossy appearance should not reappear. Now the next point is oral hygiene, and trust me, I could have put worse pictures. I had many, but we all know the feeling when a patient with poor oral hygiene enters a clinic, and we just know that this patient might not be able to maintain the composites. As you can see in this patient itself, uh, someone had given previous composites in the upper anterior region, and you can see staining very clearly. So you need to look out for these small things, right? Because for patient, even discoloration is like, poor treatment results. So in order to provide good results, you need to satisfy the patient, not just immediately after the treatment, but even after 6 months or a year. So this is not the best treatment option you can give for such patients. Or if you really want to, you might have to convince your patient to try and improve their oral hygiene and a lot of such things, right? Patient cooperation. Now, there are a lot of points in this, but some of the major red flags which you need to look out for are if the patient is not willing to revisit for follow-ups. Because in composites, you are going to need follow-ups for finishing and polishing and evaluation every 6 months. Minimum 3 months is golden. But if your patient is not willing for that, your patient just wants a quick fix and just wants to get rid of it, then probably it is going to stain over time, because we all know composite is just a plastic material and it is going to deteriorate at some point, right? So maintenance is very important, and that is one of the key factors which leads to long lasting results. Okay. So second point is, if the patient is not willing for anesthesia, there are a lot of cases where if the cavity is deep, you might have to give anesthesia, but the patient is not willing, and you just can notice that the patient is not very cooperative. We are explaining that we need to give anesthesia because this will be less painful for you, and that will be, you will just be in your zen mode. You'll have more efficiency that way. But if that is not happening, you might have to take the hint that if the patient is not very cooperative during the treatment, I'm not sure if the patient is going to be after the treatment is done, right? The third point is again oral hygiene. Suppose the patient comes to you on first day for consultation, and you notice that there is some issues with the hygiene, and you advise patients to come back after a week or two and do regular brushing, and you do scaling and everything, and you expect a better result. But then if that is still not happening, then maybe you should think about it again. And the last point is unrealistic patient demands, which we all are very familiar with, right? The first point is aesthetic expectations beyond capability of composites as well as operators, us. Okay. So there are certain limits to any procedure or anything. And composite is a very good procedure. It can be very highly aesthetic, but still probably not that much if you compare it with veneers or something like that. Obviously, it depends from operator to operator, but you need to tell this to patient. If the patient is expecting something really out of the world, then uh, just tell the patients that, hey, listen, probably what you're expecting might not happen, and I don't want you to get depressed after this. Okay. Second thing is patients who demand zero pain, zero time, and zero maintenance. So This is just not happening. You just need to be very clear with patients. Third is showing filtered pictures as references, which I also call as the chat GPT syndrome or the Google syndrome, where a patient just brings out celebrity smile pictures and a lot such things and just expects us to deliver that smile irrespective of the patient's bite, oral hygiene, or a lot of such things. And the last is demanding a brighter shade, because we all have this cliche with patients that they just want a brighter shade, right? They don't understand the SPA factor, where a certain amount of shade is going to look good for them, and all of that. And if you do give a brighter shade, later on the patient is going to be even more disappointed. Okay, so the bottom line is, do not make any false promises. Okay, don't tell patients that it is going to be a highly aesthetic procedures. Don't tell patients that there's going to be no pain, there's going to be no maintenance after this. Don't tell patients that you are going to get a celebrity smile after this, and a lot such things. Okay, we that is kind of a malpractice. That is how I see it. So it's better to just be very clear, be very honest with the patients. Patients are going to be much more happier than that. Okay, so when we take any procedure, especially composites, there is a certain protocol. Okay, you need to follow this protocol in order to achieve good results. So the protocol is to have one fixed recipe. Okay, one fixed recipe for all of your composite restorations. What will one fixed recipe give you? It is going to be simple for you to remember as well as practice over time. Second thing is, it is going to be predictable. As you do more and more composite cases, it gets more predictable with your experience. And once it's predictable, it is simple. It is very simple. The most important thing which you need to do before you start a composite restoration is you visualize the post-operative results. Okay, you should not just blindly start with composite ki bhai dekh lenge. In the middle of the treatment, you're like, okay, you know what, maybe I was wrong, maybe this shape or maybe this shade will look better, right? So this is something which you have to absolutely avoid. So as we discussed, we need to have a fixed recipe. And for anterior composites, this is my personal recipe, which I have come up with a lot of thinking and a lot of mistakes and a lot of such things. I would really appreciate if you find your own recipe anyhow, right? Because I really don't want you to just blindly follow someone's procedure or someone's protocol, and you'll just not have probably the best results. I would still want you to experiment, obviously not with patients, do it on typho, and come up with your own recipe which is going to be simple for you, right? So the first point is shade selection. That is always the first step in any composite case. The second is isolation. Third is beveling or cavity preparation. After that, we do surface treatment, then palatal shelf, followed by composite layering, occlusal check, and finally finishing and polishing. Okay, so this is my personal recipe, and we are going to learn composites in this very manner, starting with shade selection. Now, I want to tell you that why shade selection is always the first step when it comes to composite. Okay, just take a look at this case. This is a pre-op picture of a patient, a different procedure, obviously, not for composites. And as soon as I did the isolation, this was the condition. Can you see all these small white flakes, flaky appearance on the tooth? The shade just got a little brighter. And this happens because isolation leads to dehydration of tooth. Okay, so that's why you should always do isolation. You should always do shade selection first and then your isolation. Now there's one more thing to this. Once you do your shade selection, you need to stick firm with that. It is possible that during the procedure, your restoration might look a little yellowish or a little more saturated compared to the rest of the tooth. And you know what we do? We get worried. We think that, oh shit, maybe I messed up and I need to improve the shade. So you go ahead, you remove one layer and you add a brighter composite, and the patient comes 4 or 5 days after, and the patient goes, "Why is this restoration looking so bright? Why is it not merged?" Right? So that's why you need to do shade selection first, and you need to stick firm with that shade. Right? So when we are doing shade selection, there are three aspects of it. First is hue, chroma, and value. These are the three dimensions of color. Okay, we have learned this in theory. Let us understand this practically. So what is a hue? Hue is basically any color. Red, blue, orange, yellow, maroon, black, pink, fuchsia pink, whatever. Everything is just a family of color, which is hue. Now, when we go into chroma, chroma is the saturation of that color. Let's take red for example. Low chroma is low saturation. High chroma is high saturation. Value, on the other hand, is the brightness of that color. High value is bright. Low value is darker. Okay. So let's just revise this once. Hue is the color. Chroma is the saturation of that color, and value is the brightness of that color. Okay. Now, why do we need to know what hue, chroma, and value is? I mean, what do we have to do with that? The answer is because that is how our natural tooth is. We all have been doing a monochromatic restoration, or something called as with just one single shade or one single opacity of composite. But when we look at a natural tooth, chroma increases as we go cervical. The cervical third of any natural tooth is going to be more chromatic or more yellowish, more saturated, right? And similarly, value increases as we go incisally. In a way, we can consider that chroma and value is indirectly proportional. Okay. Now we all have always learned about shade. We have always learned about hue, chroma, and everything. But when we consider shade selection, we never talk about opacity. Right? I want to give you one example for this. These are the composites which a lot of dentists we usually buy because they are cheaper. We get a very beautiful, attractive offer on this. The dealer comes and they're like, "Sir, you're getting all of this for 6,000, and you'll get all of these things. You'll get a bonding agent, you'll get etchant, you'll get applicator tips and whatnot." And we are like, "Oh wow, perfect," and we go for this. And the problem with all of these composite shades or these syringes are they are all universal nano hybrid composites. Okay, they are suitable only for monochromatic restorations, right? When we talk about aesthetic restorations, we cannot use these composites because they are not going to give you a very aesthetic result. When we talk about polychromatic restorations, we need to understand that there are some aspects of natural tooth which we are just going to try to replicate, and that cannot be done with one single opacity. Okay. Now, the composites which we need should have these four opacities. When we look at any composite brand, we need to also look for the opacities which they are offering. Okay, first is dentine, which is highly opaque. Okay, very little amount of light is going to get transmitted. Second is body. It is opaque, comparatively lower than dentine, and it is going to allow lower amount of light to transmit. Third is enamel. This is going to be translucent, and a significant amount of light is going to get passed. And fourth is incisal composite or incisal shade, where it exhibits high translucency. Almost 40% of the light gets passed. Okay, we are going to understand this in detail when we understand composite layering. Okay, now the same brands, right? These are the composites which we need to have. These are the different shades. The picture on the left is 3M Z350. Okay, the earlier picture what they had is composite Z250. The only difference is uh, the Z350 comes with 4 different opacities, right? The one on the left is dentine, which is highly opaque. Then we have body, then we have enamel, and then trans, which is incisal. There are different names for different brands, obviously, but the basic thing we need to understand is these are the 4 opacities, and we need to have all of these 4, because we never know what kind of shade or what kind of opacities patients are going to come to us with. Okay. Similarly, the picture on the left, it's Ivoclar Tetragon Ceram 2, and you get shades such as A2, A2 dentine. You also get trans. You get incisal shade as flowable as trans opal. Now, we need to just look at this picture where a natural tooth has so many opacities. Okay, and this is going to be especially more significantly seen in younger patients, right? So now when we are going to do layering, there are 2 different opacities we are going to use. Okay, one is body or dentine, which we are going to apply in this manner as it is marked, and incisal or enamel composite in the other way. Like I said, we are going to discuss about this in detail once we get to it. Okay. So a lot of people ask me so many times that, so what are the basic shades and what is everything we need to get? I'm starting a new clinic, and what all should I get for aesthetic restorations? And you need to have at least one shade from all of the 4 opacities. Okay. When it comes to dentine shades, go for A2. It is the most commonly used, especially for Indian patients. A2 is the most common shade. A1, B1 maybe for younger teeth, and A3 or 3.5 for older teeth. Then body shade, you can go for A2, B2. The difference between dentine and body shades is that body shades is going to transmit some amount of light. We have understood this. Now, this all depends on the adjacent natural tooth. How much light is being transmitted? What is the opacity of that tooth? You don't want one tooth to be highly opaque and you just add enamel composite everywhere, and now it's something between translucent and gray and very dull and non-chromatic. So you need to have both dentine and body shades, enamel shades and incisal shades. Now when we talk about enamel shades, the only dimension we are talking about is value, right? A lot of brands market the enamel or translucent shades as A2, B2 or whatever it is, right? But what I think is we need enamel only in terms of value, like high value enamel composite or low value enamel composite, which is more bright or less bright, right? So enamel shades, what I've written there, HVT, LVT, are the shades you get from Shofu, and it is called high value translucency or low value translucency. There are a lot of similar shades also, but just to give you an example, this is what enamel shades are named like. Or you go to some more premium brands of restorations like uh, maybe Tokiyama or something like this. They'll have some very different names. Names such as young enamel or adult enamel, AE. So you need to look out for this. And incisal shades, again, like I mentioned, trans opal, which is personally my favorite incisal shade, it exhibits about 40 to 44% of translucency. Okay, which we are going to need for incisal detailing, right? Now, when we are going to do shade selection, there are two different methods, and it is best if you can go with both of them. Eventually, with experience, once you start to get a hang of it, you'll understand that, yeah, we can go with one method as well, any one method, right? So the two methods are taking a cross polarized picture or taking a monochrome picture. Okay. Now, a cross polarized photo is going to eliminate your hue and value. Okay. So it focuses only on the chroma, and chroma is linked with dentine shade, right? Enamel is with the value, dentine is chroma. Understand this. Okay. Similarly, monochrome picture is going to eliminate hue and chroma. So it will give you only the value. If it is brighter, if it is lighter. Okay, let us understand this now. So this is a picture, and the picture on the left is a normal picture, and the picture on the right is a cross polarized picture or a polarized picture. You can take this with the help of polarizing filters. Okay. Now, if you notice, all the bright spots on the picture on the left are gone. Okay, it is one uniform shade everywhere. That is the chroma. Okay, this is how you're going to understand the dentine shade. Now here in this picture, I've displayed the the shade tab, but actually for composites, you cannot use these Vita shade guides or something like this. Okay, you need to do the composite button technique, and we're going to get to it soon. Okay, just for the time being, understand that for chroma, we need to have a polarized picture, eliminate hue and value. Now, there is something called as personalized composite shade guides. Why cannot we use Vita shade guide? Because that is not for composites. That is for indirect restorative materials like zirconia or all those ceramics. Okay, if you look at a Vita shade guide, the shade is not uniform on the shade guide itself. If you see this picture, the shade at the cervical third on the picture on the left, the cervical third is more chromatic, right? And the incisal third is more dull, or you can say less chromatic. See, so when you are selecting your shade, what area are you looking at if you're doing it with Vita shade guide? Because the shade is not uniform. Composites, you have to do multiple shade selection, right? So personalized composite shade guide is, in simple words, you basically make your own shade guides, but the tooth in the shade guide is composite, the composite which you use, right? Just take a small amount of composite of all the shades, and you make it look like a tooth. Or the picture which you see on the left is a product which you get from Style Italiano. It is called Smile Line, where they give you this templates where you can produce these personalized shade guides for composite. And then you take a polarized picture with this, then you'll understand if your shade is similar. Either this or you do a composite button technique where you take small buttons, place it on the tooth, and then you take a polarized picture and see which merges better. Okay. Okay. So now as we step into the value, now, sadly, this is a Zoom webinar. This cannot be very interactive, but if you look at this picture, uh, can you guess how many colors are there? The first time I saw this, I thought there were like 6 or 7, right? Because towards the left, it's a little easier, but as we go, on the right, it gets difficult to distinguish between 2 colors. And what I did is I took this picture and I converted into a monochrome or a black and white picture. And this is how it looks. There are 17 different colors in that one picture. And it gets easier to distinguish between those if you convert it into a monochrome or a black and white picture. What happens with the black and white picture is you eliminate the chroma. You only have value. You focus on the brightness of that color. And we are concerned with the brightness when it comes to enamel composite. That is why we take a black and white or a monochrome picture when we are going to select the enamel shade. Okay. Now, the picture on the right, what you see, that is called as the composite button technique. You take small buttons of different shades of composite and you place it on the tooth. Just 1 second, sorry. Yeah. Now, you see there are these different shades of composite. Suppose this is A2 and you see this is A1 and this is probably A3. Now you see A2 is going to merge with your tooth much better. You can see the margins of these 2 other composite buttons very clearly, right? Now this is how you can determine the enamel composite shade. Okay, I hope this is clear with you all. So this is why composite button technique with black and white picture is useful. Now, I've already told this. These are small, quick tips or clinical tips which I'm going to give throughout the webinar. Chroma is higher on the cervical third. It is going to be more saturated. So if you notice this, when you plan to do a polychromatic aesthetic restoration, probably you'll have to use A3 cervically, A2 on the middle and incisal third probably, and then you give an enamel shade of whatever brightness or whatever shade it matches, right? For the enamel layer, chroma does not matter. Value is important. So basically, I did this one thing. I took up polarized picture of different shades, A2, A3, B2, B3, A3.5, A1, all of these shades, enamel shades, I took a chromatic picture. You know what happened? All of those were same. So it really does not matter. I don't know why it is marketed as enamel A2, enamel B2 and everything. But the bottom line is when enamel is in picture, it's only about brightness and nothing else. The third point, A2 shade of composite has greater brightness and lower chroma than A3. Okay. When we say that we need a more chromatic restoration, you need to go down. You need to go A3, A3.5. When you need a greater brightness, you go A2 or A1. But the chroma is going to decrease. As we discussed, it is indirectly proportional. Right? Okay. So we've done the shade selection. Now we move on to cavity or bevel preparation. Now there is this one very important step called isolation, which I'm going to skip because this is just a composite webinar. I want you to just consider that we have, isolated very properly. A patient is very comfortable. So when beveling is going to be in the picture, there are 3 basic types of bevels. primary bevel, secondary bevel, and starburst bevel. The starburst bevel is not always necessary to be given, but it is just one additional bevel for greater aesthetics, and I'm just going to tell you about it. Primary bevel, what is it? The objective is you make the sharp edges blunt. That is our patient, by the way, for this webinar, the typhodont on the right. Okay, so the patient had a fractured central incisor, and the fracture line, the margin of the tooth, is going to be very sharp. So the primary bevel is going to, just make it smooth. And to make it smooth, we are going to angle the burr in 45 degrees to the tooth axis. So it is, kind of perpendicular to that margin, and it becomes smoothened out. Now, primary bevel is a very small bevel, and it is limited only to the fracture margin, something like this. Okay, when you look at it from the front, I'm not sure if you can notice, but this is how much the bevel is. And I've marked it over here. So this is how it looks like. Secondary bevel. Now it involves a greater amount of tooth structure. Okay. This depends from case to case, but another thing which we need to understand is it is also called as infinity bevel, because the secondary bevel is what is going to give higher aesthetics, or this is going to help you with blending your composite restoration with the tooth. When you include greater amount of tooth structure, your composite is going to be spread evenly all over the tooth surface, and it is going to be difficult to pinpoint the margin where your composite ends and where your tooth begins. That's why secondary bevel, also called as infinity bevel, is going to improve your aesthetics. Okay, you can do this with the help of a finishing disc as well, and I would advise that more. Right, this is what the secondary bevel looks like. Okay, when you look at it from the front, this is where it ends, and it includes a significant amount of tooth surface. And it is not only to increase aesthetics, but also to increase the surface area where we are involving greater amount of enamel rods, and we have a better bond. We have a more diverse hybrid layer, which is going to help us in more than one reason. Starburst bevel, which I was telling, is basically an extension of the secondary bevel. It is basically a zigzag margin on the, a zigzag kind of a design on the margin of secondary bevel. Okay, this is going to increase your aesthetics. Basically, this is what it is going to look like. You see this? At the end of your secondary bevel, you just give additional zigzag margin, which makes it even more difficult to pinpoint where your restoration ends. Okay, so yeah, we directly skip to this slide. Let us understand what do we use to make these margins. For primary bevel, it is better to use diamond burr, right? Now in diamond burr, there is something called as Callaley burr, which is this one right over here. Okay, the shape is kind of a cone, but a curved one. This is curved over here. Okay, so you place this right on the edge, and it is going to automatically give you a smooth surface. You don't have to worry about the angle and everything. Okay, I hope you can imagine this and understand what I'm trying to say. For the secondary bevel, sorry, you can use a finishing disc like I told you, or this small instrument which you see here is called Dentsply Enhanced Disc, finishing and polishing disc, which can also be used for this. Okay, and the starburst bevel, if you decide to give, you can give it with a yellow band burr, which is fine burr. Yellow band is fine grit burr. Okay, or a Dura polishing stone. Okay, because we don't have to be very aggressive with that. Now, let us understand how bevel preparation is going to affect our restoration. Okay, so this is a pre-op picture of two fractured anterior teeth. Now, do you see this red highlighted margin right over here? Do you see the shine to it? That is the, the enamel is basically, what do you say? The glossy effect on top of that is something which is not going to be suitable for bonding of composite. Hybrid layer is not going to be formed on this. Okay, so we need to get rid of that shiny surface. Okay, and the small red circles which you see, those are the sharp points or unsupported enamel things, and we need to get rid of that too. So once we do the bevel preparation, as we learned in the previous slides, this is what this looks like. There's a significant amount of starburst bevels over here, and you see the shine which was there is now gone. Compare it with the lateral incisor. There's almost no shine over here in this area now. Okay, it is called as the prismatic enamel layer. Right? We need to get rid of that because that is not going to help us in bonding. We need the enamel rods to be exposed. We've done the bevel preparation, and let us start with surface treatment. What is surface treatment? It is the mechanical and or chemical conditioning of tooth surface, which enhances the adhesion of composite resin by improving the micromechanical retention and chemical bonding. Basically, it is going to help us to achieve a better bond, a better strength. Now for composites, there are two methods of surface treatment, etching and bonding. There are many generations of etchants and bonds and everything which are now available in the market. But personally, I always prefer going with the old school two-step etch and rinse and then bond. This one, because there's something called as a Scotch bond, which claims to be a single step universal primer, and when you just add a lot of things to that, that just does not very much satisfy me. I need to see the frosty appearance after etching. I need to etch properly. I need to feel that tactile agitation when you're using the bonding agent. So I prefer doing this, and we are going to understand about etching and bonding and the correct method of doing it. Okay, etching, it is done with 35 to 37% orthophosphoric acid, OPA, is what the other name is. Now for enamel, it is 30 to 35 seconds, and for dentine, it is only 10 to 15 seconds. Okay, because dentine is very sensitive. If you etch it for greater duration, then it is just going to give intraoperative or postoperative sensitivity, and that is something which we don't want. Why do we do etching? We do it to remove the smear layer, most importantly. Second, it creates microporosities. Okay, we are going to understand why microporosities are important soon. Third, it causes some amount of demineralization, which exposes the collagen fibers. Okay, this also helps in hybrid layer. And yeah, the fourth point, basically, it allows adhesive to penetrate, which forms the hybrid layer. Right? Now, the correct method of etching is especially for anterior restorations, is you always etch beyond the bevel margin. because we don't know where our composite restoration is going to end. Over-etching can cause sensitivity, yes, especially dentin. And as a precautionary measure, you can add Teflon tape on the adjacent tooth to prevent accidental etch. Okay, so in this picture, if the black pencil marking is where my bevel ends, this is how much etchant I am going to apply. Okay, for the reason we don't know where our composite is going to end. So we need to get rid of that too. And it is not very harmful unless it is dentin which is exposed. Now the next point is bonding. Let's just understand this, that bonding agent is basically the glue that makes composite stick firmly to the tooth. It consists of solvents which are acetone or water and adhesive monomers. Now we need to understand solvents properly, because when we apply bonding agent, solvents don't dissolve readily. You need to get rid of those solvents. Okay, I'm going to tell you how. Why do we do bonding? Hybrid layer formation, obviously. Resin tags, which is a part of hybrid layer, it blocks the dentinal tubules, leading to reduced sensitivity and obviously enhanced bonding. Now, when we apply bonding agent, we need to agitate it a little bit against the tooth surface. This is called microabrasion. Gentle air drying to remove the excess solvent. Now, like I said, there is solvent which can be water-based or acetone, or which is alcohol-based, which we need to get rid of. And that is going to, if we don't get rid of it, that is going to cause or create a thicker layer, and that is not very favorable for good, prognosis. So we need a very thin layer. Excess solvents is not the thing which we want. Okay, and obviously you need to cure it for minimum 20 seconds. I'm going to play this video where it is shown how I apply bonding agent. First, it is going to what you see here is microabrasion. This is how you need to agitate, okay, for a minimum of 10 to 15 seconds. And now after this, with the help of air spray, you remove the excess solvent. You see that rippling effect happening on the tooth surface. You need to keep doing it with gentle airflow, obviously, until the rippling effect stops. Once it stops, you know that excess solvent is now dissolved. It is gone. It is evaporated. Okay, so now you can go ahead and cure this. Now let's understand hybrid layer. Hybrid layer is basically the thing for which we've done all the surface treatment. It is a zone that is formed when the adhesive resin penetrates the demineralized dentine surface into the exposed collagen network. This is the definition which we have been learning. It basically ensures strong adhesion, it prevents micro leakage and acts as a stress absorbing zone. Basically, it is good for long lasting restorations. We need this. We need hybrid layer. Now I mentioned resin tags earlier. They are basically the extensions of adhesive resins that penetrate into the microporosities of etched enamel or dentine. You remember when I said that when you etch the tooth surface, there are small microporosities which are formed. That is where the bonding agent flows and a resin tag is formed. Okay, this creates micromechanical retention and again, obviously, reduces micro leakage. Take a look at this picture. Now, this is what hybrid layer is. The white layer is adhesive layer, which is basically the bonding agent. And you see the microporosity which was formed. The resin tag is what that microporosity is, where bonding agent has now flown. Now, exposed collagen network, the one which you see on the left, that is a result of demineralized dentine, which is a result of etching. Now, demineralization of this this layer is going to expose the collagen network where adhesive layer is going to flow. And once we cure it, hybrid layer is going to form. Okay, I hope you all got this. I tried to explain it in the easiest way possible. So basically, this is what hybrid layer is. This is going to give us better bond. It is going to act as a stress absorbing zone and no micro leakage. Before we start the actual composite restoration, let us just quickly go through the hand instruments. These are the hand instruments which I regularly use in my practice. So this picture is all the Style Italiano or LM Art set of composite or restorative instruments. The one which you see, the left one, the top one, yellow, is called Solo Anterior. The green is Fissura, and the top two, the best. These are the best two instruments for anteriors, especially. Okay. Now you go ahead, and the gray is called Condensa, which is more useful for posteriors, but can be used for anteriors as well. Then LM Art Meshura, which is an interesting instrument because with the help of this, you're going to get precisely 1.5 mm thick layer, which is going to help you in composite layering. I'm going to talk about this again in detail. Second is this beautiful instrument from Ivoclar, which is called as Optra Sculpt. Optra Sculpt pad, which is on the left, and Optra Sculpt kit, starter kit, which is on the right. And it comes with these interchangeable tips. Okay. And my favorite instrument for composites, no matter it is posterior, anterior, or whatever, it is the composite brush. If you are not using a composite brush yet, you need to buy one. These are 4 brands which are the best in business. And I've used all the first 3, obviously not the last one, but I've seen all 4 and they work fabulous. Now, we discussed about this, you remember, protocol, where we need to have a fixed recipe. And that fixed recipe, when it comes to anterior restorations, is going from palatal towards the buccal aspect of tooth. Okay, we've completed the beveling and surface treatment. Now, first thing we are going to restore is the palatal aspect, which is the palatal shelf. Then we are going to go ahead with the interproximal wall, then the dentine layer. Then we are going to do the incisal 1/3 detailing. Then we are going to do the enamel layer, and then finally finishing and polishing. Quickly, if you want, you can take a screenshot of this so that you know what is the right way to go when it comes to anterior composite restorations. A lot of people, what they do is they take a bulky, this thick layer of composite from their composite syringe on their instrument. You put it on the tooth surface and you adapt it with the help of your fingers. And there you have a very highly aesthetic composite restoration, which is going to last for a minimum of 2 days, because that is not the predictable result we are looking for. You go in this specific manner and there are very little chances of you to fail. First thing is palatal shelf. I think probably a lot of you must know this. Palatal shelf is basically the wall which is going to be on the palatal aspect and is going to be our outline. Okay, so how do we make the palatal shelf? First procedure, the first point is you make an impression of the patient's arch on first visit. Send to lab for wax mock-up. Okay, when you consult the patient, you take an impression, you send it to the lab, call the patient. Whenever you call the patient for the actual treatment, you then just ask your lab to do a wax mock-up, and you then take a putty impression of the cast, and then you transfer the impression in the patient's mouth, and you have a putty index. You have a palatal shelf. I'm going to show you a video of palatal shelf. But before that, I just want you to understand putty index so that we are on the same page as we go ahead. So I hope you all have understood what putty index is. It is basically the design of the restored tooth in advance. This is what putty index, this is what wax up looks like. See, the left picture is the picture of the cast pre-operative. This is what the patient came to the clinic with. You send this to the lab, and the lab sent you a cast with a restored tooth with wax. The picture on the right. Now this, you're going to make an impression of this cast. So now palatally, you have the palatal wall, how it should be, right? Now, another thing is, it is not always possible that you send it to the lab. Probably you don't have the best lab support or something like that. And you want to do it all by yourself without making a wax mock-up. If the defect is small, what you can do is you take a putty impression of the patient's arch, and you just visualize the amount of defect. For example, in this picture, do you see the area I've highlighted in orange, reddish color, whatever it is? That is the amount of defect we have, right? Now, according to the adjacent tooth, I want that much area to be a certain amount of, deep, and the extension is going to be the margin I want. So that much I'm going to reduce with the help of a yellow band burr, a red band burr, or a BP blade, right? And once I've removed the highlighted area, which I see, this is how the putty index is going to look like. Okay, this is basically putty index. Now, let us understand how to make the palatal shelf. You add a thin layer of translucent shade composite on the putty index we have just prepared. Add some flowable at the margin for good adaptation. And then obviously you can use a brush, the pointed brush, for better adaptation. This video is again a video of palatal shelf being formed on the putty index. Okay. So you see, we now have a outline, right? Now, in case if we're not able to make the putty index, but we still need the palatal shelf, we can do it with the mylar strip as well. Okay. So this is a freehand procedure, and you can stabilize the mylar strip with the help of composite buttons or gingival barrier, which is liquid dam, or a lot of such things. But I would advise you go for this after a certain amount of experience and practice in the field. Okay. I also have added a video of palatal shelf being made with the help of mylar strip. Let's go through that quickly. You mark on the on the mylar strip the amount of defect. You add the translucent composite. You adapt it on the tooth surface. I've stabilized this with the help of finger on the palatal aspect. Added some flowable for better adaptation, and you cured it. And that's it. You have your palatal shelf prepared. This is obviously not going to be perfect, but it is good enough to go ahead. Now that we have our palatal shelf prepared, we are going to go ahead and do the next steps. But before that, I want to show you this one photo. Now, in this picture on the right, do you see there are two different opacities? This one over here is a little translucent, and this is a little opaque, right? I'm going to mark it in different colors. Yeah, the green is translucent and the purple is opaque, right? Now, the green is the amount of thickness we need for palatal shelves. It needs to be highly translucent. It has to be a very thin layer. Okay. And another thing I want to show from this video is that when a bulky layer of translucent composite is added together, the shade we get is nothing but gray. Okay. So it is non-chromatic. It is just gray. So if you add a lot of composite, enamel composite to your restoration is going to look gray. It is going to look dull. Okay. Which again, I'm going to show you in further slides. So now, first things first, we have a palatal shelf. It looks very ugly. We're going to get rid of all the excess composite with the help of a finishing disc or whatever suits. And this is what a new palatal shelf looks like. It is just so pretty. You know, you need to have a clean environment when you're working. I could have gotten rid of this at the end as well, but you know what? Why not? Just get rid of it now itself. You'll just have a better feeling. So it's better to get rid of all of these small excess composites and these small things. And this is a clinical picture again of palatal shelf being formed. So this is what palatal shelf is. Now, I know that the palatal shelf is very thick in this case, and that is because if you notice, this patient does not have a lot of detailing. It was going to be a monochromatic restoration, right? So it did not very much matter. Going ahead, let's make the interproximal wall. You know, a lot of people, what they do is they do the dentine layer first and then they go ahead with the proximal wall. But I prefer this way. But obviously, again, experiment and see whatever you find more suitable for yourself. So there are again two methods of making the interproximal wall. The first method is the sectional matrix technique, which I more commonly use, where you basically adapt a pre-contoured sectional matrix and then you just add composite, again the transparent composite itself, and then you just adapt it and cure. This is a clinical picture of interproximal wall being formed. The second method is called Myler pull technique. Okay, the method is basically you add a Myler strip and you add some composite interproximally before itself, and now this Myler pull technique works only after you've completed the dentine layer first. Okay. So now what you have to do is add flowable as well as packable to avoid voids. This is called as snowplow technique. You add flowable composite, a drop of it, and then packable composite. And when you adapt it all together, all the small voids are filled with flowable because the flowable flows in those small voids. So you don't have voids, right? Then adapt and remove excess. You can also place modeling resin on the mylar strip and the composite. Pull the mylar strip palatally and you have your proximal wall built up. Right? There's a video of this as well. So you adapt the mylar strip first, then you add composite, flowable, packable. You adapt it properly. It is important to do all of this under the non-polymerization light. And this is the modeling resin which has been added. Just pausing for a minute. That was the modeling resin which was added. That is going to give a better, lubrication effect. And as soon as this is done, you pull it palatally. Okay. You get a very clean interproximal wall. And the best advantage of this is you'll get your line angles prepared with this if you do it correctly. Okay, so this is the interproximal wall I got with my sectional matrix, and it looks ugly again. We're going to remove the excess, and this is what we have now. Still not perfect, but it's okay. Now, composite layering. Probably the most important part, and also the most interesting one. And if you look at this picture of teeth, I've added this waves background because when you look at a natural tooth, the layering of it, this is just a piece of art. How beautifully the dentine just flows cervically to incisally. Some of it just retracts back. There are some strands of dentine. And when I'm saying dentine, I'm talking about opaque composite. Just look at it in that manner. There's some opaque composite which comes back and some opaque composite which stays there. Right? And that is what creates this beautiful effect, which is also called as the halo effect. Okay, we need to do layering in this manner, and we are going to understand this. Now, like we learned, there are two basic layers, dentine and enamel. Okay, dentine is again obviously divided into body and dentine. Enamel is enamel and incisal. Now, we learned about this in the start, and I told you we are going to go in depth when we understand layering. Okay, so just to revise this a little bit, body or dentine shade is going to be used wherever we want the light to be blocked. And incisal or enamel composite everywhere where we want a light to pass. Okay. So dentinal composite. Dentine is opaque, yellow or chromatic, and a bulky layer of restoration. Okay. Just as a small tip, you can use a shade darker than enamel composite. Okay, and it is to be added according to the anatomy. Now, when I talk about anatomy, I'm talking about opalescence. We're talking about mamelons. Okay. Now it is important that you add composite, the dentine composite, according to the adjacent tooth. You cannot do mamelons and everything, every detail, and the adjacent natural tooth does not have any of that. That is going to look super weird. Obviously, it is very obvious, but I'm just mentioning it. You need to replicate a natural adjacent tooth. Okay, that is our main aim. Okay, so you place the dentine or body composite where you don't want the light to pass, and the incisal or enamel where you want the light to pass. If the patient doesn't have any visible halo, you can do a monochromatic restoration. Okay. Now this is called opalescence. There are different types of mamelons. I'll quickly go back to this picture. Now in this, do you see 1, 2, and 3? These 3 mamelons. Okay. This is called opalescence type 1. You have something like this, where it is more than 3 distinct mamelons. This can be type 2 or type 3. Okay, let's discuss this in detail. Now, type 1 is 3 distinct mamelons, okay, which is 1, 2, and 3. Okay, this is type 1. Type 2 is 4 distinct mamelons, or if you consider this type 1, it is getting divided into 2. Okay, so this is getting divided into 2, and you have 4 mamelons. Type 3 is multiple mamelons, and type 4 is one straight line. All right. Now, I was saying this is a little bit of a theory part. but just mentioning this because you're going to look at what type of opalescence does your patient have on the natural tooth, and according to that, you're going to rebuild this. Again, sharing a video by Dr. Osama on opalescence, how to create it. Okay. Now in this, there's already dentin layer being given. Okay. We are just going to understand how to manipulate that, how to create the mamelons. The instrument being used here is Solo Anterior by Style Italiano Elimart, which I showed in the start. Now, this looks super easy, but it is really not. You need a lot of practice for this. But yeah, again, this is the fissura. And what you basically have to do is create mamelons by removing the excess in the specific portions or areas. And for this, again, you have to visualize what you want, and then you go ahead with that. So now let's add the dentinal composite layer. This is the type 1 opalescence with 3 distinct mamelons, and this is the type 3 with multiple mamelons. Okay. Now another thing is, do you see, except for these mamelons, okay, now consider this red marking as the opaque composite. Okay, there is another opaque line of composite over here on the incisal edge. Do you see that? That is what is going to enhance our halo effect. Halo effect is the the transparent composite which you see in between, the design which is created by that. Okay, so for that we are going to add an opaque composite on the incisal edge. So that this can be a dentine composite, or there is something called as direct color, which is a tint by Ivoclar. You can add white color or yellow or a mix of both, whichever is the appropriate one. And once we add that, this is what it looks like. Now, in our protocol, we decided that we're going to do the dentine layer. After that, we're going to do the incisal detailing, and only then we're going to do the enamel layer. Right? So let us go ahead, do the incisal detailing. Now, when I'm talking about incisal detailing, I am I'm just saying that we need to add a specific type of composite in the area which we have prepared. We cannot leave that as it is. And we cannot just add normal enamel composite there. That is going to block the light to some extent. Right? So we are going to add the most translucent enamel, the most translucent composite we have, which is incisal composite, which is Transopal, again by Ivoclar, and it has 40 to 44% translucency. Please excuse my terrible handwriting. Point being, it is highly translucent, and it is going to give you that that shade, that halo effect when light passes through it. Okay, that is what we are trying to recreate over here. Now, after that, when we are talking about the enamel composite, we know that we've now understood that enamel shade is mostly translucent, and the appearance is more white, or you can say more less chromatic. And it is to be added as a uniform layer, which is 1 to 1.5 mm over the tooth surface. Now, note this point, 1 to 1.5 mm. And this is where the instrument Mishura comes into consideration. You remember there was this purple instrument which had something like this of a working end, right? Now this end is basically going to be 1.5 mm deep. Once you give the dentine layer, you just use this instrument and you flow it on top of the dentine layer from mesial to distal, and all the excess composite apart from the um, more than the 1.5 mm is going to come off. Okay, you can just look it up on YouTube if you want. I'm sorry I could not add this, but yeah, this is how the instrument Mishra works. Now, once we add the enamel composite layer, this is how it is going to look like. Okay. Now let's quickly talk about consequences of incorrect layering. There are two aspects of incorrect layering. One is the thickness is not correct, or it is not anatomically correct, which is the shade or opacity, right? Now, this is what happens when you do not layer it with uniform thickness. You see these marginal stains. Everywhere you see this is exactly where the margin of composite and the margin of tooth meets. And there is some specific, very little minute amount of, step kind of a formation over there, which causes plaque formation, or, it just helps that. So this is the consequence of, incorrect thickness or incorrect layering thickness wise. To prevent this, you can use a brush, composite brush, or you can use a Optrasculpt pad. Okay, and obviously finishing and polishing. Now another thing is incorrect layering according to the anatomy of tooth. You see this entire layer of composite looks so achromatic. It looks so dull. This is probably A2 or A3, and this looks straight up B1. That is because this entire composite added here is just some enamel shade of composite, translucent enamel shade, or the nano hybrid universal composite, the composite I mentioned in the beginning, right? So this is not going to give you aesthetic results, even though the tooth form and shape is correct, but it still looks very bad. There should have been more chroma to this, and that is possible only with more chromatic or dentine and opaque shades. Now, this is a clinical picture of enamel composite layer. It is the same patient where we did the palatal shelf, if you remember. And since we are at this point, I want to mention one more important thing over here, which is called as the oil layer, also called as the oxygen inhibition layer. Okay. Now in this picture, do you see all of this glossy, resin-rich surface? Now this is called as oxygen inhibition layer. It is basically a resin-rich layer, and since this is the composite which was exposed to oxygen while being cured, it is not completely polymerized. Okay, basically your composite is just not cured entirely, and you need to cure it entirely. There are two ways to get rid of this oil layer. One is you do finishing and polishing, and this specific amount of layer gets removed, the specific thickness, or you create a barrier in between this and your curing light, where this is not exposed to the oxygen in atmosphere. And now the point is you need to get rid of the oxygen inhibition layer, because this is where plaque accumulation starts. This also affects the surface hardness, right? So you can avoid this just by adding a drop of glycerin. This is a clinical picture where a drop of glycerin is added, clear glycerin on tooth surface, and then you cure it. This blocks the oxygen, and oxygen inhibition layer is now gone. Okay, this is a small study which you can just look up on Google if you want to understand more about oil layer. Also, this is a product from Ivoclar called Liquid Strip, which is basically dental glycerin itself, which can be used to apply on tooth and then remove oil layer. Let's go ahead and understand finishing and polishing, the step where all of it comes down to whether your restoration is going to look good or not. Now, a lot of times finishing and polishing is these two terms are used very synonymously, but there are two different objectives of finishing and polishing. Finishing is meant to do a specific job, and polishing is meant to do a specific another job. Okay, the objectives of finishing are contouring, removing excess composite, and replicating the tooth anatomy externally. Okay, and polishing objectives are getting a glazed appearance and uniform tooth surface. Let's understand tooth anatomy, since we are going to now replicate tooth anatomy externally. So there are basically primary, secondary, and tertiary anatomy. Primary anatomy is line angles, which you see in this picture. On the left, this and this. This is the line angles. Then you have incisal angles, which is this and this. And you have embrasures, which is going to be between the two teeth. And obviously the buccal contour. Okay, this is the primary anatomy. Basically the form and shape and everything of your tooth. Now this is where your first year dental anatomy knowledge comes into place, where your mesial angle has to be more uh, kind of acute, and the distal angle has to be a little blunt or something like that. Let's understand secondary anatomy. It is basically the macro texture. Okay, mainly it is the V-shaped grooves. When you look at a tooth from the front, you will probably not notice this. I'm going back to the primary anatomy. Just one moment. Yeah, when you look at the tooth from front, you will not notice any V-shaped grooves present over here. But when you look at it from the side, probably 45 degrees or something like that, you will notice there is small V-shaped depressions on the buccal surface. Those are the secondary anatomies. Again, obviously, we are going to replicate it only if the natural adjacent tooth has them. Okay. And tertiary anatomy is basically the microtexture, which is more commonly seen only in young patients. It is also called as perikymata. You see those tiny zigzag lines on the tooth surface, buccal surface. That is the microtexture. Okay. Now another thing, do you notice in this picture, in the way the light is getting reflected, that shows secondary anatomy, right? This shows the line angles. So you're going to understand the tooth anatomy only with a good picture. Going next, let's remove the excess composite, basically starting with the primary anatomy. Okay, giving the contour. Now just note the disappearance of oil layer. You see, as soon as we did the finishing, this glossy resin-rich surface is now gone. We have a matte surface, which is what we want. When we are going to get the perfect incisal edge, this is how you can, note it down. The incisal edge, just take a pencil, mark it. Okay, like just take a pencil and mark it on the incisal edge and see where all it is it is not uniform. And then with the finishing disc, just use it palatally and buccally until you get a straight uniform incisal edge, a straight uniform pencil marking. Right? Line angles. Similarly, just mark line angles on the tooth surface, and with the help of finishing disc, remove the excess, or just use the finishing disc in that manner. I have a video which will see how to do the line angles and everything. This is how you mark with the help of a pencil, the line angles. It looks uniform. It does not look uniform. And this is how you're going to use a finishing disc and remove the composite between that. Now this is a smaller size finishing disc which I'm going to use interproximally. Okay, now coming up next, secondary anatomy, which is the macro texture. We are going to mark these V-shaped grooves, and it is very important that we remove or reduce a very little amount of tooth surface over here, because these are the depressions which are seen only when the light falls on them or we are looking at it from side. In this picture especially, this looks flat. This should look something like this. Okay, so we need to be very careful with this and remove very little amount. So you remove the markings with the help of a Dura stone or a slow speed handpiece and a diamond burr, and this is what it looks like. Okay, now I'm just going to do a blank screen and show you one thing. Imagine this is your tooth. Okay, and you are looking at it from the incisal edge. A lot of people think this is what the tooth looks like incisally. Okay, this is the incisal edge and this is the buccal contour. Okay, but in fact, this is what it actually should look like. These are the two interproximal margins. These are the two macro texture grooves. See over here. So when you look at it incisally, it is not like this. It is not flat. It is actually something like this, like a wide W. Okay, I hope you understood that. Now again, this is a video of me replicating the macro texture. You mark it with the pencil, and for one of the V-shaped depressions, I've used the Dura stone, and here I've used diamond burr with a slow speed handpiece. And now what you see is called again Dentsply Enhance Finishing and Polishing Cone. Okay, so there are three shapes. One is cone, one is cup, and one is disc. Okay, these three are going to be useful in different scenarios. So you use this and you kind of polish it a little bit. Okay, you can see the small, minute depressions now, especially in this picture. Okay. Going ahead, let's replicate the tertiary anatomy. Now, note one thing, that it is supposed to be done after pre-polishing. I've just mentioned it here. I'm going to tell it to you why again once we get there. Okay, so basically what we are going to do is use a coarse burr, is a black band burr. Coarse grid burr is basically a black band burr, and we are going to very gently just move it from mesial to distal. Okay, I've unfortunately again I could not add a video for this, but you can look it up on YouTube. This is what it looks like. Now let's go to polishing. Okay, in polishing also there are two different points. One is pre-polishing and polishing. Pre-polishing is done with this beige polishing spiral. The product in this image is 3M Soflex polishing spirals. There are two. One is the beige, which is pre-polishing, and one is the pink spiral, which is the polishing spiral. The beige one is going to give us an even and uniform surface. The burr marks are going to be removed, and we will get only a matte finish. Now, I said it is important to do the tertiary anatomy after pre-polishing because this is going to remove burr marks. if we do the tertiary anatomy there and then we use the page spiral, all of it is just gone. Okay, so that's why we are going to do tertiary anatomy after pre-polishing. This is the tooth which we had after our secondary anatomy, and I did the pre-polishing, and this is what it looks like now. Okay, a lot of minute amount of excess and everything is gone, and we have a better looking, even matte surface. Okay, this is a video of the pre-polishing spiral, the page spiral being used. It is important that this should be used with water. So if possible, ask your assistant to do kind of an irrigation with syringe or a 3-way syringe. Anything is fine. You can do it from the palatal aspect as well. I'm making the surface moist with the help of a cotton. We have a very uniform surface now. But notice that there is no gloss. It is shining, but it is not glossy. Let's go ahead and use the polishing spiral. Sorry, the polishing spiral, which is the pink spiral, 3M Soflex polishing spiral. It gives us a glossy appearance, and this is supposed to be used with continuous irrigation. Okay, so this is what the surface we had after our pre-polishing spiral, and this is the gloss we got. Okay, now now please note that in this you might be seeing the tertiary anatomy, just a hint of it, because I did it after the pre-polishing. Okay. This is a video of the pink spiral being used. Again, I could not do the irrigation simultaneously, but please understand that is supposed to be done. There is no use of there is no need of any diamond polisher being used, because this spiral is incorporated with diamond particles. And can you see the gloss on that tooth? And with that gloss, the secondary anatomy, line angles, and everything is just much more visible and vividly seen now. Okay. So this is where we started. This is our pre-op picture. This is the patient which we had at 3 p.m. today. And this is what we have given him back. I want you to just ignore the shade mismatch, because this is an artificial tooth, and it's very, difficult to replicate that shade. But yeah, I've given a lot of clinical tips throughout, but there are some more which I'm going to give now. First is moisture control. It is important that you do this. I've mentioned this earlier, but yeah, it is important that you do this, because if you don't do it, your composite is going to stick to the instrument instead of the tooth. So if you see your composite being, not getting stuck to the tooth, that is because isolation is not adequate. Tooth does not retain frosty appearance. This also I mentioned earlier. Hybrid layer is not going to be formed, and immediate dislodgement of restoration might happen. 2 days and patient is back. Excess removal. Now, sometimes for these small excess particles, burr or finishing disc is something which can be more aggressive. You can use a BP blade number 12 with the curved end. You can use this. This very beautifully removes all the excess composite, especially interdentally. Now, inadequate curing is another point which I want to just tell you. The consequence of inadequate curing is the depth is that if the specific depth is not cured, then the composite at the very bottom of your composite layer is not cured, and that is going to cause pain. Okay, so we can avoid this by using adequate curing intensity, which should be minimum 1000 milliwatts per centimeter square, and a specific exposure time, which is as a universally accepted fact. We have now chosen or decided that for a 2 mm layer, minimum 20 to 30 seconds of curing should be done with this intensity. Okay. And a lot of basic light cure units have only this or something around this of intensity. So we should try to keep all the increments only equal to or less than 2 mm. Now, marginal deficiencies. This is one point where which is one of the leading causes of composite dislodgement or a lot of problems, basically leading to composite failure. And we can avoid this with the magic letter magic. Okay. M, margins should be beveled and clean. Anatomic layering with correct shade, good isolation, incremental placement and curing, contour, polish, and check occlusion. Okay. Just do these 5 things and your composite is good to go. Occlusal factors. Now it happens a lot of times that we do a very beautiful restoration, polychromatic, very good halo effect, everything is nice, but we forget to check the high points. And that is the worst thing which can happen. You know, you did a very beautiful restoration, but because of a high point, the restoration is now dislodged. So you can avoid this with the help of putty index. And a lot of people ignore this, but preoperative bite evaluation and occlusal evaluation is very important. This will give you a better idea, and obviously verification with articulating paper. You can take a screenshot of this. All the black points in this picture are the the contact points in an ideal occlusion. So if the occlusion is ideal and everything is nice, any contact point apart from this is going to be a high point or premature contact. I quickly want to show you one case, even though I've showed a lot of cases throughout, but this is a pre-op picture of a case which I recently did. And the patient had previous composite restorations done here and even here. This got dislodged, and this is very not pleasing. So after cavity preparation, this is what it looks like. Now I want you to tell me, can you notice where my bevel ends? Maybe in this at this side, you can notice over here it gets ended because of the light. But the whole point is, this is what infinity bevel is. It should merge, the thickness and everything should merge with your tooth surface. That is what is going to give you invisible restorations. The palatal shelf and the the opaque line at the incisal edge. And this is what it looks like, the post-operative result. And I also want to show you this one picture. This is a post-operative photograph. And this case or this picture is very close to my heart. That is because this is the first composite case which I did probably 1 or 1.5 years ago. And everything about this composite case is wrong. Case selection, there is gingival inflammation, there's bleeding, the thickness is not correct, it's just very bad, this excess over here. There are a million points which you can note down yourself after this 2-hour lecture. And I just want to tell you that getting from this restoration to this restoration was difficult, but was not impossible. Okay. you can do this. And the only thing which you need to do this is constant practice. And just don't give up. A lot of times what happens is you do a composite restoration and you expected a better result, but then you get something and you just you settled for it, and you're like, you know what, maybe it's good like this. But trust me, the satisfaction you get after a good composite restoration is something which I cannot describe. That is the first thing I told, that composite restorations are very satisfying. You will love composites once you get to do it properly, right? And I would like to end with this one thought, that the more I learn, the more I realize how much I don't know. This was by Albert Einstein, and this is very true when we are talking about anything. In fact, uh, the more you understand about any subject, the more you realize that how much you don't know. And there was so much I didn't know about composites a year ago. And here I am today, explaining composites to so many dentists like you people. A lot of you, probably majority of you, are much, much, much more senior to me. And it shows great humility that you chose registering for the webinar by me and trying to understand new things. And by the way, this picture which you see in the background is a picture I clicked, in fact, today morning itself. And yeah, this is it. Thank you so much for your constant attention and your support and your love. And I'm truly thankful to all of you for registering. And just 1 second. Yeah. Just give me 1 minute and we'll start with the discussion session. I'm sorry, I know there is a slight delay, but we started a little late, so okay. I'm going to start from the start. Okay, the first question is from Dr. Amrit, which is, for how long, doc? 3-month follow-ups. So you should ideally, once the restoration is done, you should call the patient for 3 months follow-up for the first 1 year, and then for 6 months or biannual or annual follow-ups. Okay. Dr. Vignesh, I am so sorry, I could not, I don't remember what part you're asking me to repeat. So, polarizing filter online site or app. I am going to show this to you. I'm going to put all of these links and the products on the group. 12 colors. I'm so sorry, I don't know what this question is. Thank you so much. How or where to use the funnel shaped composite polishing disc? The funnel shaped, as in, I think you're talking about the cup shaped disc, or the finishing or polishing disc by Dentsply Enhance. That is supposed to be used palatally, because the palatal contour, if you see, you have two margins like this, and you have a shallow depth somewhere over there. So the cup is going to be perfect for finishing of that specific area. Thank you so much. What is the difference between body and dentine shade? You used dentine shade and then after that enamel, or we used dentine shade and body and then enamel. So like I said, the basic difference between body and dentine shade is the amount of opacities you need. Okay, sometimes a lot of people, what they do is they add a body shade up to the middle of middle third, and from down there you add, or you start adding the dentine shade, which is a little less opaque. So that is going to give you the effect of gradual increase in translucency. Okay, so there is no sudden jump from highly opaque to very less opaque. So that is how you can play with those two shades. Wanted to ask, how should a newbie convince patients who has not done many cases? Showing your previous cases or anything like this is a good method of convincing patients. But the point is, if you try to tell the patients that, this is the right treatment plan, and this is what is going to benefit you the most, you try to explain the advantages and everything about it very honestly. I don't think there's need of any other special convincing skills. And if the patient is still not convinced, don't do it, because just don't do it. The patient is not going to be happy, and even you are not going to be happy. What brands do you recommend for dental students? For composites, I would recommend Ivoclar. It's the best. And for instruments, I have already mentioned all of the instruments. But yeah, overall for restoratives, direct restoratives, I really like Ivoclar. And I'm not being promoted to say this, but I've personally used a lot of composites, but I really like Ivoclar. Can you repeat about pink and beige polishing spirals? Okay, so Dr. Krishna, pink and the beige polishing spirals are they are called as 3M Soflex pre-polishing and polishing spirals. You also get something called as Eve Diacom, which are again pre-polishing and polishing spirals. The pre-polishing spiral is going to give you a even and a matte finish, remove the burr marks and any small minute amount of excess composite. And the polishing spiral is diamond incorporated, and it is going to give you the glossy appearance. So that is about the spirals. Which brands and shades should be used for treating NCCLs? Dr. Yogita, I'm so sorry. I'm very bad with shortcuts. I don't know what NCCLs are. Can you please explain or elaborate? For palatal shelf, which composite use packable, flowable, or dentine enamel? You have to use translucent composite. What I personally always use is HVT or LVT, which is by Shofu. It is high value or low value translucency composite. You cannot use a dentine or a dentine or body shade, because that is opaque and that removes the entire point of translucency. Which is better, Ivoclar or 3M? Both are good, but for different scenarios. When you talk about Ivoclar composites, I really love the handling. It's very soft, it's very nice. When we talk about 3M, the composite is very rigid. It is very good in some cases where you want the composite to stay where it is, especially for posteriors when you're doing cusp by cusp buildup and or a subtractive method buildup, and you want to remove excess and you want the composite to stay where it is. That is where 3M is going to be useful. So again, I would suggest, I really like Ivoclar. You try to use all the composites you have. Talk to your dealers, ask them for demo kits and everything. Just try it out for yourself and find your own liking and dislikings. How and where to use the disc shaped composite finishing disc? You can use it for the buccal contour. You can also use it for the secondary bevel or something like that. And another thing I forgot to mention is about the Dentsply Enhance finishing and polishing kit is that the 3 tips which you get, disc, cone and cup, these 3 are finishing as well as polishing, because if you apply more pressure, they are going to remove excess composite or composite. And if you don't apply a lot of pressure, they're going to polish. That is the beauty of Dentsply Enhance. So you can use it for both finishing as well as polishing. So for the enamel, we should buy HVT, LVT from Shofu, or are there shades like A1, A2? Yes, Dr. Madhurima, like I said, a lot of shades, enamel shades are marketed as A1, A2, but the bottom line is we just need the enamel shades according to the value, the brightness of it. So you can try composites from Shofu. You can also try composites from Ivoclar or composites from 3M Z350, where they have specific enamel shades named, and you can try that. Which brand instruments to use for composites? I use LMArt and Ivoclar, Optrasculpt, and the composite brush. These are the only 3 types of composite instruments I have, and I love it. I do everything with it. Advantage of wax mock-up. The advantage of wax mock-up, Dr. Bhavna, is that you get a very precise palatal shelf. You have a very nice outline with anatomy. So you don't have to do a lot of finishing and polishing on the palatal aspect. There are very little or no chances of you having high points, and your work just becomes very easy. You're more efficient. You are in your Zen mode. So that is the advantage of wax mock-up. How can I, as a new grad dentist, improve my composite skills? Practice. Practice on Typhodont. Just take a Typhodont, you fracture it with a burr, and again on the same tooth, you build up, finish, polish, and you remove that again. And you again do that. You keep doing that. That is how I, got to where I am right now. If we follow all the steps, like you said, how long we can assure the patient that it is going to last. The thing is, there is no specific guaranteed amount of time. I have patients who have their composite as it is for 2 years now. And probably it will stay like that for another 10 years. But a good amount of time to assure your patients is somewhere between 5 to 7 years, given that they are coming for regular maintenance and checkups. Okay, I'll answer the next question. How to answer when patient asks how long the restoration will last? Oh, okay, I think I just answered this. Very similar to Dr. Lucky's question. Where to use packable and flowable? Now, flowable composite is mainly used only where you need to fill the voids, like I mentioned, the snowplow technique. So for anteriors, especially, it is more important to use only the packable, and flowable composite can be used only for the small voids or something like that. What about single step polishing? I really don't recommend something like this, and it's better to just have the protocol which you decided and just go with that. There's nothing which is easy and single step and everything. So go with the protocol which I mentioned and you're good to go. Non-carious cavity lesions. Okay, thank you so much, Dr. Yogita. So for non-carious cavity lesions, let me quickly go back to your question. Which brands and shades should be used for treating NCCLs? Okay, yeah. So personally, I use the Ivoclar composites itself, and they are good enough. Does the normal glycerin which we get in cosmetic stores work for oil layer? Yes, it does. The Bottom line being it is adequate viscous, and it is to some amount not added with excess chemicals and a lot such things. Do we need to cure after bonding agent is applied? Yes, Dr. Bhavna, we need to apply bonding agent, agitate, and cure for 20 seconds minimum, and then you start with the composite adaptation. Should we also heat up the composites before use? Okay, so heated composite technique is something which is which has different applications. Heated composite can be used for cementation of crowns or something like that. What basically happens by heating a composite is you get a less viscous composite, something like flowable composite. So you don't have to heat composite and do restorations. So that is one very common thing which a lot of people get confused about. Which brand of modeling resin do you recommend? What is your opinion about the Prime modeling resin? The Prime modeling resin is good enough. That is the resin I used first when I was very tight on my budget. I guess it is for something between 250 to 300 bucks. That is good enough. That works well. Other than that, if you are willing to spend more, you can use something called as Bisco. BISCO. You can get it on Dental Cart and a lot of other dealers. That is golden. That is the best modeling resin you can use. For midline diastema cases, I think it's a follow-up question or something. I don't understand. So sorry. Basic composite webinar. Yes, Dr. Nitin, I'll probably be doing it very soon. I actually have a lot of things in my to-do list now, so can't assure when, but sure, definitely very soon. Your opinion on applying bonding agent after we finish composite restoration. So a lot of people apply bonding agent after composite restorations just because they want to take a picture and you get that extra gloss and it looks like it's finished and polished. It's sad, but it's true. And another thing is, if there is just no use of applying bonding agent after everything after your restoration, that is like I don't know, that's the first step. It is just not supposed to be like that. So if anyone is doing that, that is probably because they are doing it to get that extra glossy effect, or maybe they think that that is going to give some extra support to your restoration, but that is going to happen only by following step 1 to step 10. Can you share the Ivoclar composite link? It is the same as Ivoclar IPS Impress composite. Yes, it is kind of the same. There are a lot of composite instruments, composite sub brands in Ivoclar. What I'm talking about is Ivoclar Tetric and Ceram 2. I will post that in the group as well. Is it feasible that we do mock-up by ourselves in clinic? Definitely, doctor. That is what I do usually, but I don't use wax. What I use is old composite, old about to expire composite. I quickly take all the shades which I'm never going to use. I put it on the tooth, I adapt it, I cure it. Done, good to go. Thank you, Dr. Bhavna. Which composite can be used for palatal shelf? We can use any translucent composite, for example, HVT, LVT by Shofu, or any enamel composite. How much charge for single tooth composite depends on you, Dr. Nitin. It entirely your choice. Can you share the name of burrs and instruments in the group? Definitely, Dr. Lucky, I'll do that. Does the normal wax warmer, which they use in beauty parlor, work for I'm so sorry, I have no idea about that. Should occlusal stamps that are available from different brands like Unique be used? Do they help in any way giving the anatomy? I'm not sure about this. Not heard of this. Maybe it is something like the clear matrix or something like that. I've not used it personally, so I cannot give a opinion as such. So sorry about that. Sir, how to go about for direct composite veneer? You do the same thing. You do beveling. It's just all across the tooth surface, and then you go ahead with the rest of the steps. Right? Composite veneers can be given. The indications are basically discolored tooth or spacing, or generalized increasing incisal height or something like that. So it depends from your case, what case it is. If it is for discoloration, you can do a normal veneer prep, which you do for ceramics, or you uniformly reduce a certain amount of tooth surface buccally interproximally if needed, and then you go ahead with layering. Could you tell us about the perikymata? Perikymata is basically the tertiary anatomy, the small zigzag lines which you can see in the young patients or something like that. So I'll probably share a picture of it in the group. Sorry about that. I'll probably share a picture of it in the group. Sorry. Do warming composite resin tubes repeatedly affect the quality of composite? I am not sure about that. To be honest, I very rarely have used the heated composite method. So I have not done it, but it is possible that, constant change in the properties and temperature and all of these things might to some extent manipulate the steps, the mechanical properties, but I don't have a scientific proof or opinion about that. So sorry. How much percent of tooth remains and when we go for composite or cap? So it actually depends on the patient itself. If it is a young tooth, if it is vital, then you can you can go for composites even after RC preps, RC treatments or something like that. It is not necessary that you have to do crown itself. If you have good amount of tooth structure remaining, you can definitely go for composites. There is not a specific percentage of tooth remaining or something like that, an index. Like I said, if the patient is young, has good hygiene, the remaining tooth has enough dentine enamel, or it's not treated or abraded, probably even 50% of the tooth can be restored. Should the glycerin be applied over the last uncured composite resin layer? Yes, doctor. Once you're done with everything, all the composite layering, and you're about to start finishing and polishing, that is when you're going to apply glycerin. Shade selection should be based on enamel and dentine. Yes, it should be for dentine and enamel for polychromatic restorations, where you first do the dentine shade matching, you decide the chroma, and then you do the enamel shade matching, and then you isolate, then you start. Would be great if you do a webinar on porcelain veneers. I have done that already, and probably I'll be doing it again, probably soon. Can you make a video with all the steps that we learned today and share it with us in the group? Dr. Yashika, I have actually done all of these videos and everything, and all of those videos are there on my Instagram handle. And in fact, that is where I have taken all of these videos from. So you can just go check out my Instagram. And if you like, do follow. my Instagram handle is srujxn_, and you can check it out. All the videos are there. Will you include the doubts part as well when you share the video, because I missed the answer to my doubts? Yes, Dr. Amrit, the recording is going to come along with the entire thing from start to end. So would you recommend some good aesthetic courses for beginners that are feasible, and also let us know the good mentors for aesthetic dentistry? Good aesthetic courses, the one I did was very good. It was a 1 year full-time course though. So if everything, time and everything allows, you can go for that in Savita. Other than that, I think there are a lot of small courses which are happening now. In fact, I am planning to start my own hands-on courses very soon. So you can go for any aesthetic courses which gives you a good hands-on practice. A very good mentor, my personal favorite mentor, who I look up to a lot of times, is Dr. Vishal Gupta, who you can follow on Instagram. He also takes a lot of hands-on courses, and you can definitely contact him, check him out. You will not regret it. What to do in cases of discolored tooth? Depends on what kind of discoloration it is. If it is something like fluorosis, yellow stains, you can go for bleaching with specific agents only. If it is tetracycline stains, it's better you go with crowns or something like a more opaque and more reliable. Or if it is localized, you can go for composites as well. So where can you share your short clinical video on group? Yeah, okay. Like I said, it's there on my Instagram. I'll share my Instagram handle itself. I think that will be, you can check it out. And obviously, you can always contact me on Instagram or on WhatsApp on the group we have, or personally, anything is fine, whatever suits you. And I'll be happy to help. Like, can composite restorations be helpful for such cases? Okay, let me go back to your previous question again. Yes, for midline diastema, right? Yes, composite restorations can be a helpful option, especially if the midline diastema is, not huge, not more than 3 mm, 2 or 3 mm, or if the patient is willing for it, given that you have explained the advantages, disadvantages, and the precautions, everything, you can go for it. It's a additive procedure only, meaning you are not going to reduce any tooth surface. You're just going to add composite, which is highly conservative. So yeah, you can definitely go for it. Can be used in enamel hypoplasia? Yes, Dr. Shanish. The thing is, now the composites which we get and the adhesives which we get now are really good, and they can bond pretty well even to dentine. So even if we have comparatively less amount of dentine, we can still go ahead with composite. It is going to be good enough. Okay. Anything else, guys? Okay. Some good polishing kits. The one I use and I have shown in this video is, as a beginner, as a student, you can go for Shofu, the the Shofu finishing and polishing discs. If you want something similar to Shofu but a little better, go for 3M Soflex discs. And then you can go for Dentsply Enhance. And the spirals. Again, 3M Soflex or Eve Dicom. Anything according to your budget. If possible, just give me a reminder. I'll put all of this in the group once I'm a little settled and my throat is back to normal. Thank you so much, doctor. I have the 3M discs and they replicate the finish you showed. Soflex, yes, it is pretty good. The 3M discs. The thing about Shofo is you can use it for a specific amount of time. After that, the finishability of the discs is just not that good. Which brand of bonding agent and etchant are good? Everything is good. It's the same content. It's just different brands and different prices. Given that it has 35 or 37% orthophosphoric acid, and the bonding agent is, the solvent present in it, and it is compatible with the kind of etchant and everything you're using. It's good to go. So better to go with the same brand. Like you can go for I go for Ivoclar etchant, which is EcoEtch or EcoEtch, I guess that's it. And I use the Ivoclar Viva pen for bonding. That's good. Thank you, doctor. It was a great session. Thank you so much. Thank you so much. I hope I have answered all of your questions. In case if I did not, please, you can post it on the group and I'll be happy to help. Are loops required for composite restorations? It all depends on you. I mean, if possible, it is definitely a helping hand, but you can do composite restorations without loops as well. It's not like a compulsion that you need to have it. Thank you, Dr. Krishna. What effect of curing light on filling? It basically cures, it polymerizes the composite. If it is done for inadequate amount of time, then it will cause sensitivity, pain, micro leakage and such things. Thank you, Dr. Amrit. Thank you, Dr. Krishna. Thank you, Dr. Yashika. And okay, I think let's just wrap up now. It's been almost 2.5 hours. This got a little delayed. I'm so sorry. There was some technical issue in the start, but thank you all for being such a wonderful, wonderful, wonderful audience. And I would definitely love to help you out or present more in future. And thank you so much. I'll just end the session now and I'll post the recording probably by 6 or 6:30. Okay. Thank you so much, guys. Thank you for joining.